I think a good place to start is with this slide again, and just to remind you that one of the defining traits of malignant neoplasms is the ability to invade. More importantly even, as a second defining characteristic is the ability to set up distant, and underline distant, discontinuous secondary foci of growth. And what this involves is cells, I was going to say breaking off, but leaving what we call the primary. Cells wandering away from the primary, getting into the moving currents of fluid of the body, let's say into the blood or into the lymph, lodging at a distance. In other words, here's the primary. These clump of cells or cells float over there. They lodge. They get out of the vessel that they're in, and they form a new nodule. That's the process of metastasis. That's what the process is called, and the focus itself is called a metastasis, or plural metastases. And the ability to metastasize, by all odds, is the most lethal aspect of cancers. And it's the feature that most often makes the cancer incurable. Sometimes the cancer is incurable because of local invasion. You know, something wraps around the aorta or some other structure and you can't get at it. That could be lethal, but it's usually metastasis. And the sad fact is that if you exclude skin cancers, many of which are in a different category, if you exclude those, about 30 to 50% of patients who present to their doctors with some signs and symptoms that turn out to be a cancer, about 30 to 50% already have metastases. So it's the thing that really is the biggest roadblock to successful treatment. So again, these defining characteristics are invasion and metastasis. Now, these abilities, to talk about first about just invasion and metastasis together, these abilities are not just a matter of cell proliferation. In other words, it's not a matter of the fact that the cancer is proliferating in the primary so much that the cells get squeezed out and they move. That's nonsense. Some primaries grow very large and never leave the local area. These neoplasms acquire, the cells in the neoplasm gradually acquire the ability to invade and to metastasize. And again, these represent accumulation of different kinds of mutations, very, very likely, giving the cells the ability to do this. Now, metastasis, I would emphasize, is a very complex cascade of events. It's not just oops, but it involves the cells, first of all, invading, getting through that extracellular matrix, breaking through basement membrane, getting into a vessel, whether it's a blood vessel or a lymphatic, floating with the stream and surviving during that flotation, which is another nice trick, lodging somewhere, being able to extravasate, get out of that vessel where it lodged, and set up housekeeping and get all of the requirements for growing another nodule. This is sort of, it's been likened to a decathlon event. You got to win a lot of events to be a successful metastasis. And there are three primary routes. This one is a little lesser, but cells can metastasize via the bloodstream, via the lymph flow, and sometimes directly. Now here, for instance, just to illustrate this, here is a clump of cancer cells within a tiny vein within adipose tissue. This was actually in a breast that had been removed by mastectomy. This was, in other words, a primary cancer of the breast. What had happened here is that a tongue of cells had broken through a venule wall somewhere upstream from this, and here you see it caught in the act of floating with the blood. Now, there's a certain predictability to where the metastasis will go. In this case, this was coming from the breast. Eventually, these venules are going to flow into veins, which are going to flow into the superior vena cava. The cells aren't going to lodge anywhere along there because the vessels are getting bigger and bigger. And it'll go into the right side of the heart, out the pulmonary artery, and pretty soon, these cells are going to encounter the capillaries in the lungs, where they're going to lodge. And so a cell clump like this, if it's successful, may very well end up in the lungs. Now you haven't studied this in gross anatomy yet, you're just beginning gross anatomy, but I'll tell you that, for instance, the blood flow draining, the venous drainage of the GI tract goes into what we call the portal vein, which is a big vein, and goes into the liver. Now the cells, if these cells had broken out from, let's say, a gastric cancer and were in the veins draining the stomach, they would go into this portal vein, and then the first capillary bed they hit is the liver. So you would find metastases in the liver. You would predict metastases in the liver. Or if you had a malignancy in the soft tissues of the leg, the cells would eventually get to the inferior vena cava, up to the heart, into the lungs. So it turns out that the lungs and the liver constitute the two big filters in the body, and they catch a lot of metastases. Now, this is nowhere near being entirely predictable for the following reasons. The cancer cells don't necessarily lodge permanently in, let's say, in the lungs or in the liver. They change their shape, they squiggle around, and they may, let's say, coming from the GI tract, they may get into the liver, they may get through the liver into the inferior vena cava, up to the heart, and out anywhere in the body. So it turns out that really, practically speaking, cancer cells, once they get in circulation, are all over the place. And it also turns out that there are secondary factors that determine where the metastases will occur. For instance, we know that cancer cells get out systemically. We rarely see metastases in skeletal muscle. I have no idea why, but we rarely do. And it turns out that certain cancers have a propensity to set up metastases in one set of tissues, and certain cancers have a propensity to set up metastases in another set of tissues. It's as if they favor the taste, in quotes, of one tissue over another. And you'll learn these patterns. I'm not going to afflict you with them, but they are, to an extent, predictable. So that's the situation with hematogenous metastases, liver, lung, but many other places as well. It's a systemic process. Here are cancer cells within a lymphatic. You probably know less about lymphatic channels than you do about blood channels, but these are basically, they start from small, thin-walled vessels like this, and any particular organ, almost all organs in the body have a rich lymphatic drainage, and the lymph is drained into bigger and bigger lymphatics, and these enter what we call regional lymph nodes, which you'll study in detail. But these are basically like little filter beans, and a clump of cells like that may well, from a lymphatic, may well lodge in a regional lymph node. Now, what's a regional lymph node? In the case of the bowel, the regional lymph nodes are in the mesentery. In the case of the breast, the regional lymph nodes are in the armpit. That's where the lymph is draining. In the case of the mouth and throat, the regional lymph nodes are here in the neck. And there's a certain predictability, so that if you have a big cancer in the mouth, you're going to worry about the cervical lymph nodes. Or the breast, you're going to worry about what's going on in the axilla. And cancer operations generally involve either extirpation or sampling of the regional lymph nodes to see whether the cancer has spread from the primary there. Now, this predictability, again, can break down because lymph nodes are not perfect filters, whatever you might think. And these cells might lodge temporarily in a lymph node, and some of their progeny may go scooting out the other side in the efferent lymph, which is going to go to other lymphatic channels and eventually dump into the superior vena cava and join the systemic circulation. So it turns out that cancer, we have to conceive of it as a potentially systemic disease. One other comment here about metastasis is the possibility of direct metastasis. And by that I mean the cells are not picked up in the blood or lymph, but if they enter a cavity, let's say the peritoneal cavity, and they can drift or swim or float across the peritoneal cavity, lodge anywhere in the lining of the peritoneal cavity, and it's sort of a direct metastasis. We see this, the one that comes to mind is ovary. The ovaries sit out in the pelvis, in the open, so to speak, in the peritoneal cavity. Ovarian cancers notoriously will just seed cells into the peritoneum, and they'll land anywhere in the peritoneum and set up these metastases. A variation on this that we don't often see is that a surgeon's knife may pick up some cancer cells, and we'll find a recurrence in an incision or something of that sort. More or less direct iatrogenic, that is physician-caused metastasis. But again, metastases represent a hop, skip, and a jump. It's not direct invasion to get over here, it's a jump to get over there. The thing to point out is that the metastasis does not have the, you'll see this in the spring, but the metastasis does not have the characteristics of the organ that it lands in. It keeps the characteristics of the primary tumor. In other words, these metastasizing cells are the genetic progeny, right, of the primary, so they're going to look like it. And if the neoplasm in the primary was making funny glands, the metastasis will probably make funny glands. It's a chip off the old block, all right? And that has some interesting implications, which you'll get into in future years. But just think of it as a process whereby a single primary can give rise to many metastases, and they can be at a great distance. It can be 4 feet away from the primary, and can be very devastating. And I will show you some examples of this. This is carcinomatosis, refers to just sort of a diffuse spread of cancer. This was the lining of the diaphragm. In other words, if I took a piece of diaphragm, cut it out, and you're looking at the undersurface of the diaphragm, lined by peritoneum, this was from a patient with an ovarian cancer. And every one of these little plaques is a few million cancer cells growing as a direct metastasis. Now I'll give you a bit of a long, shaggy dog story. Here is a specimen of peritoneum. This is as if I took a couple of pieces of body wall, cut them out, and you're looking at the peritoneal surface of the inside of those pieces, and you can see studded with a couple of hundred little tiny black spots, and here it's actually become kind of almost a confluent sheet of neoplasm. And you'd say, yeah, this looked like many little nodules. Why do you suppose it's black like that? Any thoughts? Well, those cells are making melanin. This is a malignant melanoma, which you may have heard about. Now, I'm getting ahead of your knowledge of histology, but there are no cells in the peritoneum that make melanin normally, so that means these are visitors from somewhere else. So clearly, just by the sheer numbers and by the fact that it's melanoma, we can say that these are metastases from somewhere else. I'll let the plot thicken a little bit. Here was the liver from this same case, and the normal liver is studded with probably thousands of metastases. This has grown together in a big, horrible mass which had broken through the hepatic capsule. And again, the normal liver does not contain melanin-producing cells. That fact and the fact that these are so multiple says that this liver is riddled with hematogenous metastases. Where do you think the primary was? Someone said it? Skin, yeah, that'd be your first bet, because there are a lot of skin, and melanoma is a common sort. But you're wrong. Eyeball. This was a bad picture. I screwed up. I'm not a photographer, but there you see the reflex from the flash, but just behind it, there's a little lump there, and that is the primary neoplasm. Now, this tells another story. This patient presented with a visual disturbance. The ophthalmologist saw this and said, this eyeball has to come out. And the eyeball was taken out, and it's our job as pathologists to assess whether the excision has been complete. And so we sampled the various coats of the eye thoroughly to see if the melanoma cells had penetrated through and if there were any left in the orbit. And the answer was no, looked clean. And I hope the surgeon didn't say this, but this sometimes gives rise to the statement, we got it all. Now, this patient did fine after removal of the eyeball, did fine for several years with absolutely no evidence of metastases. And then something happened, God knows what, and patient just went downhill within a period of weeks and died and had metastases all over the body. And that brings up another interesting point, which I'll just tease you with, and that is the phenomenon we call dormancy. It was very clear from the story that we had taken out the primary and there was never any recurrence in the orbit, and so what that says is these melanoma cells had gotten into circulation, that there were tiny occult micrometastases at the time the eyeball was taken out, and they chose not to grow for several years, and then something changed and they grew. And we see that sometimes. In other words, an 18-month survival or a 2-year survival or a 5-year survival is a statistical thing, but sometimes it doesn't matter. So this illustrates the fact that metastases can be very distant from the primary. They can be millions of metastases from one primary, and it also, I threw in this little phenomenon of dormancy, which is a bit unusual, but happens. Show you some other mets. Here's a lung of a youngster, and every one of these is a nodule of neoplasm. The other lung look just like this. This happens to have been a primary in the kidney, which got to the lung through the renal veins, the vena cava, and on up. The good news is we can cure many of these now, not at this stage, but we can prevent it from reaching this stage now. Here's an interesting one that we see very, very often. This is a vertebral column, which I sliced on a bandsaw. So you're looking at a couple of mirror images, and this is a pretty normal vertebra up here. This is an intervertebral disc here. And these two lower vertebrae, you see these whitish areas here and here and here and here. These were very dense bone. And interestingly, what this represents is metastasis to the bone. It stimulates bone formation around the cancer cells. It's something we call an osteoblastic phenomenon, or a blastic metastasis. This would have shown up as a density on the X-ray. Under the microscope, there's a lot of bone there, but cancer cells throughout. And usually cancer cells reach the bone via the hematogenous route. Could be anything. I mean, if someone showed me this, I'd say, well, it's metastatic something or other from somewhere or other. But you will learn, for instance, that breast cancer very often goes to bone. Prostate cancer notoriously goes to bone. And I won't bore you with the list, but you're going to learn as you study oncology what the likelihood of, I mean, if this came from a middle-aged woman and with a breast nodule, I'd say breast cancer. If it came from an elderly guy with urinary tract obstruction, I'd say look at his prostate. So that is an osteoblastic kind of metastasis. Here is a different one. This one has another story associated with it. This was a 42-year-old guy who came in with back pain, and he was a manual laborer, did heavy labor, and everyone thought at first, well, you know, this is some orthopedic injury, until they got an X-ray of his back and discovered that one of his vertebrae was essentially turned to mush. Here's a normal vertebra here, here's a disc, and this is an osteolytic metastasis. It turned out that there was a metastasis that completely destroyed the bone and it simply collapsed. Now, this man presented because of his metastasis. That sometimes happens. It may not be the primary. It turned out he was a heavy smoker, and he had a small, inapparent bronchogenic primary. In other words, a lung cancer, and it had metastasized to his bone without even causing any ruckus. He probably had a little cough, as all smokers do, but he presented because of the metastasis. This was another smoker incidence. I remember this one very well. The patient came in convulsing, signs of increased intracranial pressure. and they had to take him to the operating room very quickly to try and decompress the brain and save him just from dying of the pressure. And my colleague sent me a piece of this to look at quickly with what we call a frozen section. You freeze the tissue and make a quick section of it. And it was easy to say, this isn't a cancer arising in the brain, because it didn't look like that. This looks like a cancer that came from somewhere else. This is not rocket science. You'll learn how to do it in the spring. But it's because the metastasis resembles the primary. And we looked at that and said, no, this isn't brain. This is a metastasis to the brain. Poor fellow died shortly after operation. It turned out, again, he was riddled with metastases with a small lung primary. And lung very often goes to brain like that. Oh, one last lovely. There is a liver, and it is riddled with metastases. And if someone showed me this liver and said, where do you think it's coming from, Jer? I'd say, well, look at the GI tract. But it can be elsewhere, and this was a lung cancer that had metastasized, gotten into the bloodstream, gotten around, and liked the taste of liver, and produced metastases in the liver. There were metastases in many other places as well. Well, that gives you a little bit of an example, a little bit of a feeling for the destructiveness of this process of metastasis. And again, benign neoplasms do not metastasize, only malignant ones. And benign neoplasms do not invade, only malignant ones. Ah! Don't want that. All right. With those concepts of neoplasia, I hope you've all got benign and malignant invasion and metastasis sort of under your belts. I want to talk for a little bit on how neoplasms are put together microscopically. And again, don't worry about being able to do this kind of diagnosis yourself, but just listen to the concepts. I want to review the concept of stroma, the concept of differentiation, and ideas of grading and staging. All right, let's begin with the business of stroma and angiogenesis. One of the things that I should emphasize, I didn't really emphasize what I've shown you so far, is that a given nodule of neoplasm, take one of those metastases in the liver, for instance, a given nodule of neoplasm is just not a spherical collection of 100% cancer cells. It's a very important concept. And it makes perfect sense, because you could not possibly grow a lump literally that big and have a blood supply to the cells in the center. You follow me? In other words, if it were pure cancer cells, the blood would be out here and these cells would be proliferating here. It doesn't work that way. The cancer needs a blood supply in order to grow. And it turns out that cancers are able, and this is a very interesting phenomenon, to induce the formation of what we call a stroma. It's a fibrous and particularly a vascular framework which supports the neoplasm. Now, the stroma is not part of the malignant clone or the neoplastic clone. It comes from the connective tissue cells and the blood vessel cells around the neoplasm. And the neoplastic cells and probably some of the inflammatory cells accompanying the neoplasm are able to induce the formation of this stroma. It's very much like the induction of granulation tissue, which you're very familiar with from last week. And what happens is this fibrous and vascular stroma grows into the nodule and enables it to proliferate. We talk about tumor angiogenesis. I mean, the emphasis being on the blood vessels. Now, there's abundant experimental evidence to show that, and I won't go into the details, but if you create a situation where you've got a bunch of neoplastic cells growing pure, where they can't pick up a stroma, the nodule will never get bigger than 1 millimeter or 2 at the very most, probably less, because the oxygen and nutrients cannot diffuse in a solid mass any further. And there are many experiments that show you grow neoplastic cells in these little balls and they stop growing. And then if you do something to induce angiogenesis, boom, as soon as they pick up the vascular stroma, they begin to grow. So tumor angiogenesis is exceedingly important. You can read, I won't bother you with the details, but we're beginning to know a little bit about how this is mediated. And what it looks like is this. Again, without too much detail, this was a lump in a breast. This was a breast cancer. And these dark clumps are the cancer cells. And the pink in the background is the stroma. And I'll emphasize in particular, there is a capillary there. There is a capillary kind of cut lengthwise there. There's another capillary there, and so forth. So that any given clump of cancer cells isn't very far from a capillary. That's the concept of a stroma and tumor angiogenesis and what it means. If we could stop angiogenesis, we could stop tumor growth. It'd be wonderful. And some of these attempts have reached the clinical testing stage, but nothing terribly dramatic yet, but it's certainly a handle. Here is kind of a loose stroma, not very fibrous, but a lot of blood vessels. Sometimes it can be very dense. These are cancer cells in a very, very dense collagenous stroma. This kind of a lump has a consistency about like wood. We call that, it's an adjective you'll hear occasionally, call that a SCIRRHOUS, S-C-I-R-R-H-O-U-S, a SCIRRHOUS mode of growth. But whatever the variation, any lump of neoplasm has this vascular stroma that it has induced. Okay, go on to the next concept, and that is related to the fact that since neoplastic cells are derived from a previously normal cell population, they're going to share many, many of the genetic traits. They're going to have some new ones because of these mutations, but they're going to share a tremendous genetic background with the parent tissue. So they're going to resemble the parent tissue to some variable extent. I mean, sometimes very sharp resemblance, sometimes maybe not much of a resemblance. When the neoplastic tissue resembles the parental tissue, the normal tissue, to a high degree, very close resemblance, we speak about that neoplasm as being well differentiated. It's a funny phrase, I didn't invent it. But when we say well differentiated, that means it looks just like mom and pop. On the other extreme, it may look nothing, and I'll show you some examples, may look nothing like the parental tissue. We say that is a poorly differentiated or an undifferentiated tissue, neoplasm. There's another phrase, another word that's sometimes used, and that's anaplastic. Anaplastic refers to, well, some people say de-differentiated, but undifferentiated. It's just an immature, undifferentiated tissue we refer to as anaplastic. And there's a complete range of possibilities. Now let me illustrate this for you in the two extremes. Here is a view of the normal colonic mucosa. And we're going to talk about this in detail Wednesday. But the mucosa has these kind of tubular glands. That's all I want you to get out of this. This is perfectly normal. The next slide will be a cancer derived from this mucosa. It looks like that. Now you say, oh, that doesn't look anything like it. But in a sense it does. It's got glands. They're kind of funky and kinky and so forth. But they're clearly glands. You will also notice that the pink to blue ratio has changed. A lot of hyperchromatism and a lot more nuclei here and so forth. But basically, a pathologist looking at this would take about a nanosecond, as you will this spring, and say, oh, this is a glandular type of neoplasm. So we'd say this is at least moderately differentiated. Now I'll show you a step down. Here's a normal bronchial mucosa. Again, don't worry about the details, but there are these tall columnar cells. Some of them are secreting mucus. Others have cilia on them. Very well organized there. The next slide is a neoplasm derived from that cell population. If someone showed me that, I'd say, I don't know what that is. That is an undifferentiated malignant neoplasm, or an anaplastic neoplasm. And when you look at that, what it really says is it's a population of cells that's not maturing. You can't tell what it's doing, where it came from, but it sure as the dickens looks malignant. Look at those huge nuclei, an increase what we call NC, nucleus to cytoplasm ratio. They are pleomorphic, they are hyperchromatic, there are tumor giant cells there. This is really, you'll learn to look at those things and load them. You'll say that is an ugly cell population. So that is a highly anaplastic cell population. Now, it turns out, well, let me give you a rule of thumb first. Benign neoplasms are always splendidly well differentiated. Sometimes you get in the middle of a benign neoplasm, you can't tell it from the normal tissue. So benign neoplasms are always well differentiated, almost perfectly differentiated. Malignant neoplasms show the whole range. There are very well differentiated, but nonetheless malignant neoplasms. And there are highly anaplastic neoplasms like this. Now, in some situations, in many situations, in malignant neoplasms, there is a rough correlation, I emphasize rough, there's a rough correlation between the degree of differentiation and the behavior. This is not uniform for all neoplasms. And remember, well-differentiated neoplasms, cancers can still kill. But for some situations, it's a useful label that we give it to send to our colleagues, where we say, we label it depending on the degree of differentiation. We call this grading, histologic grading of neoplasms. And the grading of neoplasms is really, as I said, an assessment of the degree of differentiation of the neoplasm based, I mean, we look under the microscope and we say, oh, this looks just like such and such tissue. That's well differentiated. We sometimes take into account in these grading systems the number of mitoses. That's a little less usual, but it's based basically on the degree of differentiation. And we talk about grade 1. Usually grade 1 means the best differentiated, grade 2, grade 3. Some grading systems are all the way through grade 4. You get the idea. I mean, you'll get the details. But when we label with the grade, we say this is well differentiated, and our colleagues at the other end say, well, maybe that'll behave a little better than if Abrams said it was anaplastic. And I'll show you what this amounts to visually. Again, don't worry about being able to pick these out. Here is a carcinoma, a cancer derived from a squamous epithelium, like the epidermis of the skin. And the trained pathologist, which you will be next spring, would look at this kind of arrangement, or all this pinky cytoplasm, which represents keratin in the cells, and you'd say, oh, easy. That's a well-differentiated squamous cell carcinoma. This might be a grade 1, for instance. This one is not going to look like much to you, but a trained pathologist would look at this and say, well, this isn't terribly well differentiated, but I can still see areas where I'll bet that's come from a squamous epithelium, so that would be maybe a grade 2 or moderately differentiated. Here again is a completely anaplastic cell population. Someone showed me that and said, where's this coming from? I say, God only knows, this is cancer, but I don't know what kind. This is really an anaplastic, probably grade 3, or in some schemes a grade 4 cancer. And again, there's a rough correlation between the degree of differentiation and how it might behave. Now, grading, this is all microscopic. Grading is different than staging. And please keep these two straight and read and understand. You're going to deal with these two concepts all your lives. Staging of neoplasm is very important because the stage that we assign to a neoplasm tells the observer how far along in its natural history that neoplasm is. In other words, how big is it in the primary? How much tissue has it penetrated? Has it advanced to the point where it's spread elsewhere in the body? That is staging. And it's based on, first of all, the size and the extent of the primary, the presence or absence of regional lymph node metastases, and the presence or absence of distant metastases. This is sometimes referred to as the TNM system. T for tumor, what's doing with the primary. N for regional nodes. M for distant metastases. And every organ has a slightly different staging scheme, but they're all based on this. And what it gives you, if it's a low stage, or a favorable stage, that says this tumor hasn't advanced as far. Maybe it's restricted just to the organ and the lymph nodes are negative and there are no distant metastases. Or it may be that it's penetrated quite a way through whatever organ it started in and there are already lymph node metastases, but we don't know of any distant metastases. That's quite a different situation, which may take a different therapeutic approach. And then finally, if there are already distant metastases, that's a very, very different thing. So staging gives you a very important handle on how far along the neoplasm is in the particular patient and what you should do therapeutically because of that. Well, now is not the time to dwell on how we tell benign from malignant. In our daily work, you will again get an appreciation for this next spring. But suffice it to say that we pathologists can look at a tumor and make some pretty good predictions about how it may behave. In other words, if we look at a tumor and it looks very, very well differentiated, it's completely circumscribed and so on and so forth, we say that's benign. And what that says is if you get that whole thing out, patient's home free. And if it's invasive, anaplastic, and so forth, it's a very different situation. And I can tell you that the cornerstone of clinical diagnosis in the field of oncology is getting something under glass and getting it in the microscope. Very few instances where therapy will be undertaken without confirmation of the fact under the microscope that it is such and such a cancer and such grade and so on and so forth. So it means we need a piece of the tissue or at least some cells from the tissue to get under the microscope. And what we rely on there, as you might surmise from what you've seen, is first of all the cytologic features. How anaplastic looking are the cells? How bad is the pleomorphism, the hyperchromatism, etc.? We rely on that. We rely on the relation of the cells to one another, the loss of polarity in the system and so forth. And we rely on the relation of the tumor to its surroundings, the nice pushing margin versus, boy, there goes invasion. It's that sort of thing. Now, I'll give you just a very quick example of that. Here is you can imagine that colon I showed you in the cut. Here is the mucosa, the submucosa. Here's the muscular wall. Here is a tumor arising in the mucosa. And you see it's under the microscope here. You can see kind of glandular spaces there. Look what's happening. You've got glands penetrating clear down through the muscle there. That's a no-brainer. When we see something like that, we say it's invading, it's malignant. Right? That makes sense? Sometimes we don't rely entirely on that. We rely on other things. The cytology, just quickly. There are normal colonic epithelial cells. I'm not even going to describe these. I'll just let the pictures speak for themselves. You'll catch up with this in the spring. Here are neoplastic epithelial cells. Again, normal, neoplastic. Here's a normal squamous epithelium. We're back to cervix as an example. Here's normal squamous. There's dysplastic. You saw that before, this variation, this loss of polarity, the individual features of the cytology here. That's a degree of dysplasia. That's a step towards cancer. And this one, we said, was full thickness awfulness with very anaplastic cells. I won't go into the details again. The concept is important. When dysplasia gets severe, it's tantamount to cancer in situ, whether or not it's invaded. You see, in the colonic example, we showed you invasion. Here, we can say this epithelium is cancerous, damn it, whether it's invaded or not. And you've got to get it out or something bad is going to happen, because virtually 100% of these severe dysplasias will invade. And that is carcinoma in situ. And you'll hear a lot more about that. Now, clearly, if you look at something like this, you realize that individual cells in that population bear the imprint of their malignancy. In other words, they have these anaplastic traits, and you can say these are malignant cells. A guy named George Papanicolaou, over a half century ago, realized that this was a great handle, that if you just took cells that exfoliated, that is, dropped off the surface of a place where there might be a tumor, that these exfoliated cells would bear some of these traits, these anaplastic traits, and all you'd have to do is look at the cells and say, wow, this is so-and-so. And that, I'm sure you're aware, is the origin of the so-called pap smear. And the beauty of the pap smear is you don't have to cut out a piece of tissue from the person. All you need is a sample of, usually it's mucus, over the area. Now, this has been perfected, and it's changed the whole face of how we deal with cervix cancer. But you can imagine a cervix, now let's back up, looking like that, and the cells that are exfoliated, remember they come off here, and getting a pap smear involves getting a little bit of mucus scraped off the surface, and it'll pick up some of these cells. And from a normal epithelium like this, you're going to see, and I'll show you a pap smear, normal cells, whereas from this or this, you're going to get a different kind of cells exfoliating out, and without really having to get a big piece of tissue, you get a little bit of a swatch of mucus, you can tell what you're dealing with. I'll let you see this for yourselves. Well, here are just some of the cellular features of anaplasia. Any look at a cell population like this with these huge nuclei, there is a tripolar division figure there. Those are the kinds of features we look for. All right, here's a normal pap smear. You look at that without any training at all, and you'd say, well, those cells look like one another. Look like they're all out of the same cookie cutter, the same NC ratio, the nuclei are not pleomorphic, they're very regular, et cetera, et cetera, et cetera. Normal pap smear, next case. Now, suppose that epithelium looked like the bad one I showed you. There you are. I mean, I'm showing you the extremes. Instead of being very regular, these are extremely pleomorphic cells with increased NC ratios, hyperchromatism, and so forth. The cytopathologist looking at this doesn't have to pause very often and say, this has been exfoliated from malignant cell population. And the nice thing is that in between, the cytopathologist can also look at this and say, well, this probably came from a cervix with moderate dysplasia, or minimal dysplasia, or something like that, so that not only can we catch cancers when they're perhaps too small to appreciate by ordinary examination, we can actually catch dysplastic epithelium before it's become cancer, or carcinoma in situ before it's invaded. These things are all invisible pretty much, and it will show up on the cytologic exam. So it's become a very, very powerful screening tool. And it's changed the face of what we see in the way of cervix cancer. When I was a kid in pathology, we used to see nothing but very advanced cervix cancers that were clear into the rectal wall and the bladder wall and so forth. And I haven't seen one of those, thankfully, in decades. because of the application of the pap smear as screening. And that's something you'll hear a lot more about. So going back to generalities, the definition of, or the diagnosis of neoplasm requires getting something under the microscope. Now, sometimes it's the whole tumor. A patient presents with a lump somewhere. You cut out the whole thing. That's called an excisional biopsy. And that's very nice because if it's benign, you're done. If it's malignant, you have to do some other things, very likely. Sometimes only a piece of tissue is removed. If it's a big mass, you don't want to go and do a commando operation until you know what you're dealing with, so there may be an incisional biopsy. You take a wedge of it out. There are various, you'll see all these various biting forceps where you bite a piece out. And there are punch forceps, particularly for skin things, where you take a punch. You know, it's like a little boring. Finally, very often there are varieties of needles that are used, where you can put a needle into a mass with nothing beyond local anesthesia even, and put a needle in and draw out a core of cells and get those under the microscope. And the extreme of this is putting in, and this can be done, you know, with CT guidance into internal organs, put a very fine skinny needle in there and suck out some juice from the lump, and that juice will usually contain a few floating cells, and the trained cytopathologist can look at the degree of anaplasia and so forth in those cells and make a diagnosis. So this is almost always what we do before undertaking treatment. And I just tell you in conclusion that this visual examination under the scope is frequently augmented by other things. Someone asked me, for instance, can you always tell looking at a metastasis where it came from if it's an unknown primary? My answer was no. Unfortunately, many different glandular neoplasms look the same under the microscope. So all we can say is this came from a glandular tissue. But sometimes we can use immunohistochemical techniques. In other words, there may be certain proteins on the surface of certain cells that identify them. And we have a library of antibodies directed against these various proteins, and they're labeled in a certain way, and we can make a cut of the tissue we have and put this on, and if it lights up, we know that that protein is represented. I'll give you a concrete example. Suppose we had a lymph node that had a glandular cancer in it, and one of the possibilities would be from the prostate. We could take an antibody to PSA, prostate-specific antigen, stain that tissue, and if it lit up, if those cancer cells had the prostate antigen, easy, this came from prostate. So we use those sorts of things. We've gotten into molecular methods of identifying this or that molecule in the cell population. That augments what we can do visually. And the ultimate is something you're going to hear a lot more about, and that is subjecting the tumor to analysis with what we call microarrays, which are it's a system whereby you can screen for thousands of genes and see which ones are activated. And we're beginning to be able to say, well, with this, and these genes activated, this neoplasm is more likely to do this, and with this set of genes activated, it's more likely to do that, and that's where it is all going. Okay, we'll continue this on Wednesday and then feed you to